So, ventriculomegaly, how do we define it? In the fetus, we define it by the diameter of the atrial width, which is more than 10 mm, which we usually measure in the second and third trimester. So, you should mind. So, this has to be measured in the second or third trimester. We do often get a referral mentioning that there is a ventriculomegaly in the first trimester during the NT scan. So this you should avoid to mention in your report. This has to be done in the second trimester during the time of the anomaly and onwards. So later on there can be a ventriculomegaly after like 16 17 18 weeks, but this should not be done earlier. And this term hydrocephalus that we often use in the postnatal period is interchangeable. So how do we define it? Its differences. So hydrocephalus, it's a pathological dilatation which occurs because of the obstruction. And ventriculomegaly, this can be because of the obstructive cause as well as the non-obstructive causes. So then how you are going to assess that whether there is a ventriculomegaly or not? So obviously this has to be measured as we have defined it by the width of the atrium, which is more than 10 mm. So this we assess in the transventricular plane. And what is the atrium? Atrium is the part of the lateral ventricle where this is the occipital horn of the lateral ventricle. This will come the body, and inferiorly the temporal horn will come where they join together. This is called the atrium. And we measure the lateral ventricle width at the level of the parieto-occipital sulcus. So this plane you should be familiarized and try to measure the atrial width in this plane. So what all things we are seeing in this plane we call a transventricular plane. So in the midline you can see this is the midline falx, which is interrupted by the rectangular shaped cavum septum pellucidum. This is the level of the thalami. This falx, it continue posteriorly. So this is anterior falx, this is the posterior falx. In the midline we are seeing the two thalami. It is interrupted by the cavum septum pellucidum. This is the midline structure. Literally what you are seeing here is this is the Sylvian fissure. This dip, this is diamond shaped. This dip is the parieto-occipital sulcus. So what is its significance in cases of the ventricle, like in transventricular plane? So we measure the width of the atrium at the level of the transventricular plane. You have to mind your calipers. The caliper inner margin, it has to be placed at the inner margin, and this has to be perpendicular along the long axis of the lateral ventricle. So you cannot measure it like you should not measure it like this or like this or in this plane. So it has to be, caliper has to be inner margin to the inner margin and perpendicular along the axis of the lateral ventricle. And this is the parieto-occipital sulcus. So you should try to familiarize yourself with its appearance. This is usually visible after 19 weeks onwards. So this measurements has to be taken at this level. And while acquiring the transventricular plane, you should be careful that both the cerebral hemisphere, it has to be symmetrical. So there should not be any obliquity. So by this, you are measuring one side of the ventricle. So we have two ventricles. So we need to measure the other ventricle as well. For that, we need to make the angulations with which the other ventricles will be visible. So remember this plane, the cavum septum pellucidum has to be visible. Two cerebral hemisphere, it has to be equal size. Midline falx, it has to be visible. Parieto-occipital sulcus, and measurements has to be taken at the level of the parieto-occipital sulcus with caliper placed along the inner margin to the inner margin. And as I told earlier, that this has to be measured like in the second trimester, not in the first trimester. And it has been seen that this remains stable throughout the gestation. In the later half of in the later pregnancy also, this atrial width, it should not exceed more than 10 mm. Now, this we have already discussed. We have talked about the transventricular plane, and what else you are going to see in the transventricular plane. We have seen, we should note the dilatation. Once you have seen the dilatation, what you are going to see. So this cavum septum pellucidum, you see it's a rectangular box. So if there is any alteration in the appearance of the cavum septum pellucidum, as you can see here, it is appearing more like a square shaped rather than a length is here, the length is more than the width, but here both are almost equal size. So there might be associated ventriculomegaly in that case as well. So this reflects, this could be a partial agenesis of the corpus callosum. So and then as I was telling, we should measure the other lateral ventricle as well, because because of the artifacts of the calvarium, we are not able to see the near field lateral ventricle. So for this, we need to make an oblique angulation to visualize this lateral ventricle width, and you should document this width in all your scans, because there are often cases of the unilateral ventriculomegaly as well. If you are not doing that, then you will miss this diagnosis. And apart from that, when you have seen the ventriculomegaly, what else you are going to see is to see the adhesions. Is there any adhesions? If they increase, so you can appreciate there is here the periventricular echogenicity is increased, and there are a septae within the lateral ventricle. So this is an adhesions. Now, how do we classify the ventriculomegaly? We classify ventriculomegaly, either we can classify it as a mild or severe, or we can categorize in the three parts: mild, moderate, or severe. Mild, if we are dividing into the three categories, we call mild up to 12 mm, moderate between 13 to 15 mm, severe more than 15 mm. And if we are classifying into mild or severe, then we call it as a severe when it's more than 15 mm. This width is more than 15 mm, and mild between 10 to 15 mm. And there often happens the asymmetrical ventriculomegaly, in which there is difference between the two width of the both the lateral ventricle. If its difference is more than 2 mm, then we call it as asymmetrical ventriculomegaly. So once you have seen a ventriculomegaly, it's not a diagnosis. It's just a manifestation of the various diseases in the CNS as well as the extra CNS system. So when you have seen the ventriculomegaly, you are supposed to perform the detailed evaluation of the fetal central nervous system examination, which is the neurosonogram. Apart from that, you are supposed to visualize the spine and detailed anatomical evaluation of the fetus, because they are often associated with the other extra CNS malformations. And once this is evaluation is done, then we should evaluate for the fetus, for the fetal infections, because the ventriculomegaly has been associated with the fetal infection, and for that you should look within the CNS as well as extra CNS location manifestation of the fetal infections, which could be, we might sometimes see the ventricular calcifications, hepatic calcification, there might be ascites, polyhydramnios, oligoplacentomegaly, hepatosplenomegaly. So all these things we should look for. And very often we encounter mild ventriculomegaly in our scan. This is an benign, often an incidental and benign findings, but any fetal ventriculomegaly, it warrants detailed evaluation, because it is often associated with the genetic, structural, and neurocognitive disorders. And uh, for that, we should advise the, apart from the ultrasonographic detailed evaluation, we should advise for the invasive testing, which is the amniocentesis. And there are other structural abnormality within the central nervous system, such as agenesis of the corpus callosum, Dandy-Walker malformations, malformations of the cortical developments. They also lead to the ventriculomegaly. And the most common cause of the severe ventriculomegaly is the aqueductal stenosis. We know that aqueductal stenosis, it results because of the narrowing of the aqueducts of Sylvius, and this leads to the progressive dilatation of the third and lateral ventricles. So this could be because of the genetic causes, or this could aqueductal stenosis, it can happen because of the infections or any hemorrhage or any fibrosis which has led to its stenosis. And often the aqueductal ventriculomegaly, it can be because of the fetal infections also. And there are other causes of the ventriculomegaly apart from the structural abnormality, infections. It can be associated with the trisomy 21. So mild ventriculomegaly is also a soft marker, aneuploidy marker for the trisomy 21. And there could be a chromosomal or genetic disorder which are associated with the ventriculomegaly. So this brings us about how you are going to investigate this case whenever you come across a case of a ventriculomegaly. So you should perform a detailed neurosonogram, which I will discuss what all the planes we are going to see. We should evaluate the detailed anatomical evaluation of the fetus to rule out any extracranial, extra CNS manifestation. After that, we should perform the invasive testing because amniocentesis, and we often advise for QFPCR. This is a rapid testing. You should be just aware in your PG sections that once you have, if someone is asking for your opinion also, you should be aware of what all things we are going to do. So mild ventriculomegaly, we should not leave as it is because this can be associated with the infections. This could be because of the trisomy 21 or other chromosomal single gene disorders. There are so many causes of the ventriculomegaly. So you should ask your obstetrician to, or you should suggest your obstetrician to perform the amniocentesis, in which you will advise. This is a test which is done to rule out, commonly we perform to rule out the trisomy 21, 13, 18 and sex chromosome abnormality. Chromosomal microarray, we tend to evaluate for the smaller deletions, duplication, and then we advise the exome sequencing, in which we perform the to rule out any gene disorders which are at the gene level. And apart from that, we should evaluate for the fetal infection. So we should advise maternal torch evaluation, and if we are performing the QRP amniocentesis, then we can send the amniotic fluid for the PCR of the torch infections as well. So when we are performing the neurosonogram, transventricular plane we have already discussed. So this is the transthalamic plane. So we perform neurosonogram in axial planes, in coronal planes, and sagittal planes. In axial plane, we have three planes for the evaluation of the fetal brain. One is the transventricular plane, transthalamic plane, and transcerebral plane. So when we are acquiring these sections, so transventricular plane come in the top. Below that comes the transthalamic plane, and after that comes the transcerebellar plane. So in the transthalamic plane, we are very familiar of this plane because in this plane we do take the measurements of the biparietal diameter and head circumference. So what are the landmarks for the acquisition of the transthalamic plane? So this is again, this midline is the falx, which is interrupted by the cavum septum pellucidi. These are two other thalami. These are the hippocampal gyri. And this is posterior falx, the symmetrical two cerebral hemisphere. This is the Sylvian fissure. We are very nicely ossified mineralized calvarium. So in this plane, we measure the fetal head circumference and biparietal diameter. So what information this plane gives us? So this gives us about the fetal head size. So if there is any microcephalic cases, so head circumference will be very small. It will not be as appropriate to the gestational age. Apart from that, what we should see in this patient is this is the sulci. So this is the Sylvian fissure. So we should see its appearance or morphology of the Sylvian fissure, whether it's appropriately developing or not. So if there is any lag in the development of this Sylvian fissure, then it might suggest that this would be a lesioncephaly or malformation of the cortical development. These two basal ganglia, we should see it symmetrically. In the transcerebellar plane, this section we acquire little down toward, if we come from the head towards the neck region or caudal direction. So this we acquire a transcerebellar plane. So what we do in the transcerebellar plane, we measure the transcerebellar diameter. This is the cisterna magna, fluid collection behind the cerebellum, and we measure the nuchal fold thickness. So what all the things we are going to roll out, we are going to see if there is any cerebellar hyperplasia, because there are various syndromes which are associated with the ventriculomegaly. So we should take the measurements properly in a proper plane to avoid any diagnostic error. So we can rule out the transcerebellar plane. We can rule out the enlarged megacisterna magna, thickened nuchal fold, or any anomalies which are involving the posterior fossa, such as the Dandy-Walker malformation, Vermeer's agenesis, or hypoplasia, or BP cyst. These things we can rule out in the transcerebellar plane. After that, we evaluate the fetal head in the sagittal section. So this is a mid-sagittal plane. So you can see see, this is the hypoechoic structure. This is the corpus callosum. This is like how we see in the MR. So this is the corpus callosum. This fluid collection below it is the cavum septum pellucidum. This level is the thalami. Here is the midbrain, and this continue inferiorly as a pons and medulla. And this bean shaped or kidney shaped structure is the vermis. And you can appreciate the vermis. There is slight lobulations. So these we call as a fissure. So we divide. This is the primary fissure, and primary fissure. This form the upper part, which is 1/3, and lower part is the 2/3. So you should be well familiarized with the normal appearance in the mid-sagittal plane. So what we are going to rule out. So if there is colpocephaly or there is a ventriculomegaly and corpus callosum is not visualized in the mid-sagittal, so this suggests that this could be a agenesis ventriculomegaly secondary to the agenesis of the corpus callosum. If there is any abnormality in the vermis is rotated or upward or fourth ventricle. So this anechoic structure is the fourth ventricle. So this fourth ventricle, it might be open, the fastigium will not be seen. So this will help to evaluate the posterior fossa malformations. And we also see the morphology of the vermis. So here you can see this morphology of the vermis is not normal. So what we are seeing, it's more thicker in the inferior part. Here it is not thick, it's dysmorphic appearing. So this is this is how we evaluate. So this is the cases of the vermian hypoplasia. And we should also appreciate this is there is a pontine bulge. So this bulge has to be maintained. So we take the width of the pons, whether this pons is normal thickness or not. So this is roughly how we are going to evaluate in the mid-sagittal plane.